Welcome to Columbia University's Department of Biomedical Informatics. My name is George Hripcsak, and I'm chair of the department. I'm going to be talking about our research, our education, and our service, and here you see our group gathered for a retreat. We're the second oldest biomedical informatics department in the country, founded by Paul Clayton, our first chair, who was followed by Ted Shortlift. We became a formal department in 1994. We have 45 total faculty. About 27 of them are full-time, with 25 PhD students and other trainees. Our budget's around $16 million a year, and we have beautiful space on the penthouse of Presbyterian Hospital. Let's talk a little bit about the research. Our research spans from atoms to continents, doing molecular dynamics, computational biology, working in physiology, working in hospital systems, working with populations, and installing health records in 11 countries in Africa. We did social network analysis on ourselves and found that we are really three groups of scientists: the natural scientists or data scientists, the people who are interested in social science, and the people who are engineers who build systems. We're a highly collaborative group. Shown on the left is a social network of us. See, it's tightly coupled versus the typical basic science department shown on the right. Everyone's on everyone else's papers and grants. Let me go through a bunch of our research to give as examples. I won't highlight particular faculty members, but you can see that on the website. To start off, we do a lot of observational research, that is using data collected in the process of healthcare to learn new things about medicine. This particular thing I'll be going to more detail later, Odyssey, Observational Health Data Sciences Informatics, based on a network of 600 million unique patients, in this case showing how diabetes, hypertension, and depression are treated today around the world. We put things into practice. In this case, reading a patient's chart, if it's very long, is difficult. And so we use AI techniques to read the entire chart and provide a summary to the clinician as a word cloud. And as you click over the word cloud, it quickly brings up what evidence it used to put that note there and shows you the timeline. In this way, doctors and nurses and other staff can quickly review the patient chart. This is used a lot by ED doctors and by quality nurses, we found. We studied medical residents to see how we can improve electronic health records for them. Notice the orange, that's where they're actually in patient contact. So indirectly, we showed how much time doctors spend thinking and managing information versus actually in contact with the patients. We do a lot of work in the EHR and measuring the impact of those interventions, as shown in three examples here. We've recently moved to the Epic system EHR, and we're putting decision support using their tools now. It's hard to believe that 1 out of 200 medical orders are actually on the wrong patient, or 1 out of 200 notes are written on the wrong patient. We've put in interventions to reduce that amount. And we put decision support for genomic medicine into the electronic health record to make recommendations on when genomic testing should be done. We engage patients in their care, both at home and even in the hospital. We gave patients tablets so that they could know who their team was and what treatments are being given to them while they're in the hospital. And of course, we help them manage their disease at home. We do this in part using predictive models, in this case, data assimilation to predict glucose, so that we could help patients better manage their diets in the setting of type 2 diabetes. Here's an example where we study diseases that are less well characterized, in this case, endometriosis, using social media. We apply novel approaches to data science to our work, in this case, applying generative adversarial networks to electronic health records to improve controlling of confounders. We use graphical models for causal inference, showing how we can improve, again, handling confounders. One important thing about the department is that we don't just apply existing methods, but we invent new methods. In this case, deep survival analysis was developed at the department. We tend to publish in the literature both in biomedical informatics and in computer science, as well as statistics and data science in general. We support not just clinicians, but also the researchers that carry out clinical studies. Our database comprises 6 million patient records, with a great deal of information that's been collected over 30 years. The department has a large translational bioinformatics portfolio that combines the information from clinical records with biological information, in this case, to find novel drug interactions, in this case, one that could be fatal. And more generally, we carry out network medicine, again, combining the clinical and the biological information. And we can improve our genomic analyses using clinical data from our database. Then we do deeper analysis in genomic medicine, in this case, using mathematical topology to better understand glioblastoma, using network analysis to better understand autism and why men are more affected than women. We're also addressing de novo mutations in coronary heart disease. In computational biology, we use both data science and a deep knowledge of biology. In this example, avoiding the cancer becoming resistant to the cancer drug by applying that drug to a cancer bottleneck. We're published in top journals, as shown here. On the bottom is an example of a collaboration where 4 medical students led a study of COVID as it first came out and published in British Medical Journal. The Columbia University Data Science Institute is an amazing resource. The department actually helped to create it and helps to run it today. And its Health Analytics Center facilitates a lot of data science research in healthcare. The National Science Foundation has a set of regional hubs, and Columbia is part of the Northeast Regional Hub, and we helped run that. The Observational Health Data Sciences and Informatics, or Odyssey initiative, has over 300 collaborators from 30 countries, and Columbia is the coordinating center for that. We have records on about 600 million unique patients. We do large-scale observational research, in this case showing the problems in the medical literature and how Odyssey can address them. The department's deeply involved in precision medicine. We collect and manage the phenotype. We do predictive analytics. We do the bioinformatics analyses. We deliver results to healthcare providers and patients, and review previous genomic results to make sure they're up to date. This architecture, this diagram was created by the department to illustrate the precision medicine being done at Columbia. As a part of that initiative, we became part of the All of Us research program. First, recruiting almost 100,000 participants in New York. And second, we're part of the coordinating center, where we use the Odyssey infrastructure to store data for the All of Us research program. We're part of the eMERGE network, again, using the Odyssey infrastructure to carry out research across the clinical and biological side. In addition, we're highly collaborative, working with the Department of Systems Biology, which is kind of a sister department, the Informatics Intervention Research Center, and then a number of other initiatives that we're part of. Moving now to our training program. We have a broad portfolio of programs. We train PhD students, master's students, postdocs, both those entering the field and those who are advancing their career. We have an ABMS subspecialty fellowship, and we teach the medical students and also have a certification course. The PhD program, which is helped by $1 million a year training grant, we pull in about 6 students per year. We have many graduates, most of whom actually go into academics and have a great track record of publication. Postdocs, again, with great publications and moving on to leadership roles around the field. Our subspecialty fellowship is in collaboration with clinical departments and has been very successful. We teach the medical students who are threaded through all the years of the medical student curriculum, as well as doing summer research and a student-run innovative medicine club. We take diversity and structural racism very seriously. We have a number of ongoing activities. We welcome input, for example, from our own trainees, and we've been reformulating the structure of our department to better address these issues. New York Presbyterian Hospital is our living laboratory, where we supply to them services, and they give us the opportunity to carry out research in that environment. We provide decision support, we help on precision medicine, we run the clinical data warehouse, and a number of other activities on the hospital side. We also help the university with their electronic health record of EPIC, and as well as the Columbia Biobank and other activities. Our motto is discovery and impact, and our values are innovation, reproducibility, collaboration, community, openness, and beneficence. So once again, welcome to the department. Please visit our website for more information and feel free to email any of us for more information.